heading to Mexico.
All right, so I'm going to start over here, and then I'm going to join our colleagues. So I realize that we are all that stands between you and the bar. That is not an enviable position to be in. So our panel today is going to focus on the big picture trends, the megatrends that are driving the future of health information exchange and interoperability. Now, most of these trends are linked closely, but not only with the U.S. federal government. And before I set the stage for our discussion, and then we'll get into talking with the panelists, I'd like to introduce our panelists, who represent both key federal agencies and then highly respected private sector organizations. So on my immediate left, he's on the next page here, of course, I've got Walter Suarez, and Walter is a physician and public health and medical information system specialist. He's the executive director of Health IT Strategy and Policy at Kaiser Permanente, and he's responsible for KP's internal and external e-health and HIT policy positions, providing national and international leadership. He's on the NCVHS, and in fact, in 2015 was appointed chair. He served on the Health IT Standards Committee, and was founding president of the board of directors of the Public Health Data Standards Consortium. Walter's a founding member of the Digital Bridge Initiative, as well as the Gravity Project, which you heard about earlier, focused on social determinants of health, and is very active in a number of standards development organizations. He's the incoming chair of HL7 and is also a member of the board of HIMSS North America. Walter earned his medical degree from the Colombian School of Medicine and his MPH from Tulane. Next, we've got Alex Mugge. So Alex is the Deputy Chief Health Information Officer at CMS. She's been with CMS since 2010, and during that time she's worked on a number of CMS quality reporting and value-based purchasing programs, really with a focus on health IT, and she and I worked closely together over the years. Before joining the Office of the Administrator in her current role, she was Deputy Director of the Division of Health IT, and she led the overhaul of the EHR incentive program and its progression through a series of acronyms. Alex earned her MPH at the Rollins School of Public Health at Emory University, where she specialized in public health policy. And now we've got Paul Matthews. So Paul is OCHIN's Chief Technology Officer and Chief Information Security Officer, and he manages the architecture and interoperability of OCHIN's national EMR and data analytics business lines. And over the last 2 decades, Paul has led implementation of health IT within the ambulatory market, with a special and very important focus on the safety net. Paul's passionate about the operational integration of HIE within the safety net environment, and among the organizations that he serves on are the Sequoia Project Board, the eHealth Exchange Coordinating Committee, and the HIMSS Interoperability and Health Information Exchange Committee. Locally, he's also heavily involved in Oregon organizations, for example, the Central Oregon Health Information Exchange. And finally, we've got, the first one, of course, John Rancourt. So John is the director of the Interoperability Division of the Office of Policy at ONC. John's division supports health IT policy implementation through such activities as the Trusted Exchange Framework and Common Agreement, the TEFCA, state and Medicaid interoperability, public health, which we heard about earlier from John Lunsk, including the opioid emergency, value-based transformation as it's enabled by health IT, consumer engagement and data access. And during his career in health policy, John's worked on Capitol Hill as a patient advocate and as a journalist. So welcome. So before we get into our panelists, I'd like to take just a few minutes to highlight developments that have brought us to where we are today with interoperability and health information exchange. Now, clearly, the federal government, as I said, working with the private sector has played a central role. Before and after the infusion of federal funding with the 2008 HITECH Act, I can't believe it's been that long, we've seen both growth and consolidation, both of them happening as we sit here today, in HIEs and in nationwide interoperability initiatives like the eHealth Exchange. We've also seen the important role of progressively more robust ONC certification criteria and the resulting health IT capabilities. And the sort of complementary CMS-led meaningful use quality payment program, PIP, MIPS, et cetera, and the acronyms, as drivers, all of them working together as drivers of standardized exchange. Now, notably, we've also had increased focus on consumer access to data through the interaction of the CMS and ONC view, download, and transmit requirements, and more recently, API access. And we're now starting to see accelerated provider and developer experience with API access using FHIR, well, mostly using FHIR, but we'll be moving more to standardization, as part of the latest version of MIPS, meaningful use, and the required use this year of the 2015 certification. And we also saw how ONC, but really handing it off to the private sector, has grown the direct messaging standard. And standards have certainly played a key role in this growth. The IHE profiles that are so important for eHealth Exchange, the HL7 CCDA that Didi was talking about, terminology standards like SNOMED and LOINC, and the increasing use of structured and standardized data, and the rapidly growing and maturing duo of the HL7 FHIR standard and SMART. And critically as well, and we've heard this acronym a few times, the USCDI, reflecting the importance of standardized data sets. Now, with the 2016 21st Century Cures Act, we've seen more focus on broad and deep access to health data, especially for patients and their designees, using both trusted exchange and APIs and apps. Notably, we have the ONC proposed rule to implement several cures provisions, and I think Alex will be talking about that a bit. Notable highlights for that rule include the focus on information blocking, and I'll be on a panel dealing with information blocking tomorrow with several of my colleagues from the Interoperability Matters Project at the Sequoia Project meeting tomorrow, APIs and certification, and the USCDI. And ONC also has issued the second draft of the Trusted Exchange Framework and Common Agreement, the TEFCA, this past April. And the Sequoia Project, as you know, has been named as the Recognized Coordinating Entity, the RCE. And there are several sessions on TEFCA tomorrow afternoon at the Sequoia annual meeting. Now, CMS, and Alex and I were talking very briefly, she's been busy, CMS has been busy, focusing on increased patient access to data through the My Healthy Data initiative, including Blue Button 2. And along with the ONC proposed rule, CMS also issued last spring, I think this was in the middle of HIMSS, a proposed rule on interoperability that complemented the ONC work on open FHIR-based APIs, focusing on health plan APIs and health plan engagement with Trusted Exchange, very important for eHealth Exchange. So as we look back on what we've accomplished and we look ahead to our panel, I'd close by highlighting a few high-level megatrends to keep in mind. The importance of APIs and apps, the importance of patient access, and particularly as expressed through the HIPAA right of access, and also, and something we're all going to be living with for some time to come, the focus on elimination of information blocking. National connectivity initiatives like Care Quality, eHealth Exchange, and Commonwealth, an increasing interest in payer-to-provider and payer-to-payer interoperability. Privacy and security, especially in the non-HIPAA space, globally, not just in the US at a national level, state and beyond HIPAA, patient matching, and social determinants of health. Now, at this point, I'd like to shift to our panel and we can dig deeper. So the first question, and I'd also encourage you all to interact with each other, and if you want to disagree violently, that'll be some good entertainment. So I'm just going to go right now in order with starting with Walter. So Walter, for Kaiser Permanente, what are the most pressing barriers and challenges to interoperability from the standpoint of Kaiser? What are you seeing?
Well, thank you first for inviting me to participate in this panel. I think, first I want to say, one of the perspectives about interoperability is, and someone said it the other day, is interoperability is about 20% technology and 80% about policies and processes. And the reality is that I think we have the technology to achieve interoperability. We are lacking certain elements. And so the other point I wanted to make is what is it that we really think interoperability is at the end? So we have all sorts of definitions, that's the good news. But the important part to us is what is the ultimate goal of interoperability? And to us, the way we see it is the goal is to achieve the following, that the information about the right person is available at the right time to the right person, whether it's a physician or someone else, all the time, in real time, and in a secure manner. So that is ultimately the goal of achieving interoperability. Now, if we measure interoperability based on purely the amount of data that is being exchanged, we probably are much better than where we thought or some of the news tend to portray. We exchange a lot of data. But if we measure interoperability based on this more outcomes-based definition, I think we have a ways to go, because we are still not able to really achieve this goal of making the right information about the right patient available to the right person at the right time all the time. So what are the barriers that we see? The number one, I think we see barriers around the complexity of the information that is going to be exchanged. It's not a simple packet as an ATM message that goes between two machines. It's a complexity of information that involves variability every time there is an exchange. So if it's a patient from a nephrology department or a person from a cardiology department, there is multiple different variables, different purposes, different times. So that complexity creates a challenge around interoperability. The second one is, I think there are some infrastructure elements in our system that are lacking that create barriers. I mean, we can go over it, but we still have to resolve them. And there's three that I wanted to mention. One is the lack of a patient identifier. The second one is the lack of, and along the way, the lack of a provider identifier, ultimately. The second one is the lack of a robust provider directory where not only we identify providers, but we know where they are so that we can exchange data with them to the right location. Because that's one of the barriers that create a challenge of, am I sending data to the right provider? And there is legal and implications. And the third one is the lack of a strong record locator system where we can point to, this is where the data is so that I can go and access it. So that's another big barrier. The other one I wanted to highlight, I think, is the lack of semantic interoperability. I mean, we can achieve all the components of interoperability, but semantic interoperability is still a challenge, an issue, because we can send the right data in the right format, and the other entity can receive it. The problem is the data itself, the language in which it's written. And then the last one I wanted to mention is, I think it's still a factor that affects the ability to interact and interoperate, is we're still living too much in a fee-for-service world, where the incentives are not necessarily towards sharing more information. Until we move more into a value-based care approach or model, where there is incentives. And there is actually demonstrated, even by ONC's own numbers, there is demonstrated effect of how much more information exchange and interoperability happens among organizations that are on a value-based care model versus a fee-for-service model. So I think those are some of our challenges.
Alex, from the CMS standpoint, what do you see as the barriers and challenges that you're grappling with?
Well, Walter took a lot of mine, so I'm going to see if I can give
that's why I sat here.
That's why you went first. So I'll see if I can give it a different spin. But I really liked the way you started by saying that interoperability is really 20% technology and 80% policy and other, we'll call them human factors, to exchanging data. And you are correct that we have the technology. But what we are seeing is that there isn't that consistent implementation of the technology, consistent adoption, and the right use of standardized data or adoption of standardized data elements to make that technology work well for interoperability. So I think that those are major barriers and challenges that we will continue to face. And I know that a lot of work has been done in that space, and ONC has done a lot of work on the US CDI and other data standardization, but we have just a long way to go. So that's going to continue to be a challenge. But one of the things that CMS has focused on from sort of, I won't call it the start of our interoperability work, but where we've recently sort of restarted our interoperability work is focused around the patient access piece. And our administrator tells a great story about when her husband was traveling and was admitted to a hospital away from home. And when he was being discharged, she asked to get access to his information because she realized she was taking him home to Indiana and his doctors at home wouldn't have that access to that data. So she asked for a copy of his medical record, and they didn't know what to give her at first, but she ended up walking out with a CD-ROM of his data and had no way to read it because she didn't have a CD-ROM drive in her computer. And wasn't really, and it turns out not all of the data was even on the CD-ROM once she got it home. So if, you know, ever since her initially telling that story in the office, we've all exchanged stories where we have had trouble accessing our own data as patients. And, you know, everyone's a patient at some time or another, and so each of us, whether it's for an annual physical or something else, you know, we've all sort of tested the waters of getting access to our own data and found that that we've all had similar problems, which is really interesting because we're not average Joe patients. We all work in healthcare and we work in patient access, and we have really close, great friends at OCR that can tell us exactly what the patient right of access means and define it for, you know, for anyone who asks, but yet we still can't get access to our own information, and it's just shocking to think about. So that's really where the foundation of our interoperability rule started, was really focusing on getting that patient access, and from that a lot of other pieces of interoperability are starting to fall into place. But we still have a lot of those challenges, a lot of what Walter talked about, and just getting that consistent technology and the agreement of everyone in the healthcare industry to focus on exchanging data because it's critical for patient care.
All right, thanks, Alex. Paul?
Well, I tend to approach the question in a different way. I'm more practical than policy-based. I have great policy people that work with me. But I look at it this way. I've got patients, 10,000 providers, 5.6 million patients over 28 states, all in the safety net. So I've got my patient population is roughly running at 50% of those patients are under 200% of the federal poverty level. 50% of those patients have mental health as a chronic issue. And when we actually look at the exchange of data on those patients, regulatory burdens are really our biggest issue. So, or should I say, regulatory and individual policy issue decisions. So if I look at the exchange of data in a community-based health center who may be participating in substance use disorder treatment programs, and I have patients signing the authorization for the release of their patient data for treatment to the next provider. What I find is often that the person that's supposed to receive that information won't query for it. They don't want that information sent to them. And why don't they want it sent to them? Well, we have no methodology in which tagging information within inside of the EHR allows me to tag the information as sensitive, and it's being addressed within inside of the rules, the proposed rules. But this brought up a massive backlash from my provider community. Their concern is I start now putting the onus on the provider to tag information within inside of a system, and it's going to put additional burden on the provider in an already stressed system. So I try and look at it from how am I using the system from a user's perspective, and then look at the other policies aligned to that. A great example for me would be exchange of data from certain states, where state policy doesn't allow for me to actually gain access to that information and incorporate it into the medical record of a patient, because I actually have providers that provide services across multiple state lines. So how do I gain access and exchange data, make use of that information, if the state policy will not allow me to pull that information out of that state? Okay? It goes further down the pipeline. Individual exchange organizations or individual partner medical record systems whose internal policies don't allow for the exchange of information because they are concerned about the actual exchange of that data being intermixed with an organization or organizations that cross state boundaries. And so we see these over and over and over again from a practical solution, and that isn't going away. And the reason it doesn't is mainly because participation agreements are a risk to an organization if they need to re-sign them. We've seen that recently, right? We've sent out, Jay is out here sending out his DERSA amendment agreement for signature. There's a risk in sending out an amendment to a contract, and people are looking at that going, what's my return on my investment? And is it worth me re-signing that system, or should I just pull out? And so those are the big areas I look at on this. But if we can sort of look at it from a more practical solution, at a patient level, I'll give you an example. 2017, we turned on patient access through the APIs under meaningful use to their data. Since 2017, one patient has accessed that system. So we've got a system that is looking for an application, and Apple went a long way to doing that. But again, one patient has accessed those medical records through that platform. So I don't mean to be a Debbie Downer, right? I really want to look for practical solutions, but sometimes we have to actually think about what's the impact at the patient for all this technology and all this investment that we're doing.
Just a quick follow-up before you. So when you talked about the risk of signing a revised agreement, could you just expand a little where that risk comes from?
Yeah, I think there's a couple of things occurring, right? We've got competitive risk. What happens if an organization is going to go out to the market and ask its participants to sign a new contract? And they are not necessarily seeing the value in that organization's services because it may have been superseded by other services, or it may be that they've seen a change in their practice or a change in their partners in a community, and therefore no longer need access to that service to get the same value. They may no longer sign that participation agreement, and therefore they'll actually be moved out of that organization, and therefore the actual hosting organization that's providing that service no longer has the finances to survive. That's going to accelerate organizations' issues around sustainability, and you'll start seeing collapse of organizations and more mergers occurring. And that's not just individual HIEs, that is state-level HIEs, that is organizations in the EMR field. Everybody is feeling that.
Thanks. And as we turn to you, John, I just observed that I think that's relevant, and we'll have some discussion tomorrow about TEFCA and some of the conversation there about needing to sign new agreements. So thanks for expanding.
Yeah, and we can talk more about that too, as that plays directly into why we are doing what we're doing related to TEFCA. So Mark, really enjoyed your introduction there to sort of frame where we're at and where we've been, and wanted to start also by thanking you all for having me here today so that we can talk a bit about what ONC is doing and why. And it comes from a point of history where we have done a ton as a nation to digitize our nation's healthcare system. The work that you all are doing today, if we could go back in time 8 years and look forward to the types of conversations, the types of technologies and solutions that are made available now, it's just really astounding and excellent. But the interoperability that our healthcare system needs is not there. And those computers that we've put into the healthcare system don't talk to each other the way they need to. And Congress recognized this, as you pointed out, Mark, with the 21st Century Cures Act. And that gave ONC new authorities to address what we see and what Congress saw as major barriers to interoperability. That includes information blocking. That includes the lack of interoperability among networks, which is what TEFCA is looking to address, but also talked about trying to reduce the burden that is put on providers due to health IT, which Paul was talking about. And ONC is doing work in all of these areas, and we'll talk more about it on the panel, but we do have a burden reduction draft report, which we're actually partnered with CMS on, since it's really something that isn't just a technology ONC type of thing, but is really has a lot of CMS components to it. But as far as TEFCA goes, I did want to touch on, one of the key challenges that we hear about is the overall cost and complexity of legal agreements. In fact, it's AHA survey data that found that 78% of hospitals have to use more than one method in order to get the data that they need, more than one interoperability method. So they're doing all of those re-signing and legal costs over and over again. And TEFCA looks to address that by creating a baseline set of legal and technical requirements that then can be built on for different use cases and different communities, et cetera. Information blocking is happening and is a problem that we are working to address by regulation. Of course, we have all the disclaimers that we'll talk about there as far as the limitations of what we can say, but we have a proposed rule, if you haven't heard, and are working very hard to finalize that so that we can begin to move past a lot of those barriers.
All right, thanks. So as we move from the barriers and the challenges, wanted to get into the strategies of each of your organizations. For the two government agencies, what are your strategies really to advance interoperability? And then for Kaiser and OCHIN, what are your strategies to respond to regulatory developments and uncertainty? So why don't we start with you, Alex, just from the CMS standpoint on your strategies. You touched on them a little to advance interoperability around My Healthy Data and some of the newer things that have come this year.
Sure. So first strategy is finalize our interoperability rules. Very important.
And when is that going to be?
Let me give you an exact answer. So hopefully soon. And so that, we're very enthusiastic about that. I'm sure ONC is as well. We're very excited to finalize our rules. But we're continuing to look at all of the policy levers that we have to identify additional opportunities for the future. So potential future rulemaking. Some of you have mentioned to me that you noticed we have another interoperability labeled rule in the unified agenda, and that is correct. We're going to continue to look at all the levers that we have to encourage interoperability and data sharing. But just some of the ways that CMS is, we like to say that we're leading by example, and some of the data sharing efforts. We have our Blue Button 2.0 initiative, which is Medicare fee-for-service's way of sharing claims data with beneficiaries through APIs. We also, over the summer, recently released or announced the Data at the Point of Care pilot, which is an API that shares fee-for-service claims data directly with providers. So providers can sign up to say, this person is my patient, and I would like their claims data to see their health or their treatment history, and access that directly from their EHRs. So those are a couple of ways that we're leading by example on the API front, and that we're very proud to be working with industry partners to further promote with other payers and with the EHR vendors. In addition to that, we're looking at, we recently launched a focus on provider directories. So Walter, you'll be happy to hear that we are looking at one of those major barriers to interoperability, and that we understand there is no interoperability if you can't find the other provider to share data. You can have all the data and be willing to share it and have it in a standardized format, but if you don't know where to send it and don't know how to communicate with that other provider, then you're at a dead end. So this is a problem that we've heard considerably through stakeholder feedback, as well as through some responses to our first proposed rule, where we had have multiple proposals about provider directories, but none which addressed the actual accuracy of provider data. So that's something that we received the feedback. We definitely heard from folks' comments, and we're going to react to that by looking at ways to improve provider directory accuracy and healthcare generally data accuracy. So it's not just about providers and finding other doctors, but also about finding the right ways to contact payers and hospitals, facilities. So trying to find a way to streamline that. So those will be a couple of things that we focus on in the coming year.
John.
Yeah, so I'll reemphasize TEFCA, information blocking, but also mention the API, condition of certification, which will create standardized APIs. That's going to make data flow more easily. And so would have several things to talk about, and that we work very closely with our CMS counterparts on all of the things that Alex mentioned there, whether it's patient matching. We had an RFI in our proposed rule on that topic and are examining those responses that we got there, are looking at that topic very closely as it applies to, for example, the realm of opioids and prescription drug monitoring programs. We held a workshop on that topic, just released a whole bunch of slides from that workshop, so a lot that we could talk further on, the things that have come up already on the panel, but that really is a very challenging problem that has a multifaceted nature to it that we are looking at and are trying to advance on that question. We're engaged in numerous other efforts as well, beyond those that I've just mentioned and mentioned earlier, which includes work to try and enhance interoperability via Medicaid programs, for example. So how are Medicaid programs designed in order to advance value-based payments and to consider the data needs that are associated with those and the health IT infrastructure needs? We were talking a little bit about challenges associated with lack of health IT interoperability infrastructure, and there is a lot of money that's still available for states to use Medicaid matching dollars to build some of that infrastructure. Some of that is also specifically around opioids, and that's 100% matching dollars. So working very closely with states on those opportunities. Want to also briefly mention our work to try and expand the world of those that are connected into our healthcare system to consider emergency responders, for example. And we have our Pulse project, which I'm not sure everyone is aware of, but I do see Kate Kiefert, who's our contractor, supports us on that work, which is really exciting stuff to provide access to Pulse for first responders. And so nevertheless, there are numerous other activities that we're engaged in that I did want to bring up.
Just a quick follow-up before I turn to Walter and Paul. And you sort of alluded to part of your responsibility is to bring in others like behavioral health that maybe haven't been connected as well, and opioids. And obviously there's some of the issues around 42 CFR Part 2 and practices that are dealing with data sort of in and out of that category. And I know SAMHSA had I think a draft out on some revisions, and I believe I recall when I was reading that ONC had some part in the development of that. Is that an area that ONC is dealing with? Sort of, I know you've got some of the data segmentation issues, but some of the practicalities of helping provider practices deal with some of those issues where they have data that needing various levels of protection. Is that at all an initiative area for ONC?
So yeah, let me make clear, yeah, it is a SAMHSA rule, so cannot speak to that, but we do work very closely with our federal partners on their rules and provide them with input based on our understanding of the health IT ecosystem and technology, so on and so forth. We also provide support for example, states through technical assistance activities, either through that Medicaid work that I mentioned or through our support for Center for Medicare and Medicaid Innovation models. We do technical assistance work there where states are trying to build either with, for example, SIM dollars, systems that can enable electronic consent management, for example. And sort of jumping ahead to your third question of like what are the interoperability advancements that we're looking at or hearing about, this was one that I wanted to mention, which we're hearing about a lot, is e-consent management. And in fact, I just heard that the Washington Healthcare Authority is going to be piloting a e-consent management tool next year that will be, according to them, be able to, maybe Paul, you can talk more to this, be able to handle 42 CFR Part 2 types of data. So,
Thanks.
yeah, a lot going on there.
So Walter and Paul, we're going to just switch to your sort of side of that, which is our friends here, John and Alex, issue with many other colleagues regulations, and you all have to deal with theirs as well as things in Oregon, multiple states. So Walter, maybe to start, what are you seeing as the ways in which Kaiser Permanente is responding to regulatory developments and regulatory uncertainty around some of what we're hearing about?
Yeah, I mean, this year has been one of the most intense years in terms of regulatory activity because we address, and inside Kaiser we have a team, my team, that looks at the health IT, federal and state regulatory, legislative, regulatory, and sub-regulatory policy development. So this year we scored more than 120 different initiatives with more than 10,000 pages of regulations. And you have to think of some of them are proposed and then final. So very, very significant. What we have tried to do is begin to shift our mindset from being more reactive and sort of behind the curve in terms of what regulatory developments happen, to being more proactive and being more ahead of the curve and engage early and often in the process and advocate for different positions through different vehicles. We go directly ourselves in terms of responding to, through comment letters to requests for information or proposed rules. We also go along and work with our partners in the industry. But it is a big challenge because there are multiple elements, multiple areas, spaces, if you will, domains, not just interoperability and information blocking, but we have to deal with FDA and FDA guidance in most cases, and NIST and FTC and all these other agencies that basically are coming out with regulations, sub-regulatory action. So very intense and significant. We had to establish a very deliberate process to ensure that information that is in those proposed rules can be brought in quickly into Kaiser to review and to then respond appropriately. But I give you an example of how challenging this is. Many of you saw the publication of the final rule on discharge planning, just September 29, I think, September 30. Well, inside that rule, not a lot of we don't necessarily notice it very clearly or quickly. There was a requirement that now, as part of discharge planning, you have to do or incorporate into a CCDA dialysis care plan and dialysis discharge summary or care summary. And that was to happen 60 days after the publication of the final rule, which was September 30th. So by November 30th, I guess, we had to put in place that. And it was something we weren't necessarily following in our radar. So we have to be very active, very proactive, very thoughtful in terms of, in terms of all the things that we do. But a couple of points I wanted to make also. One is there's now a question in our minds, in terms of how much in the regulations in the future that we see, we should expect a designation of very detailed, specific standards by version and by subversion and reference points. Because we are now getting into a level where there is concerns about, having standards on regulations that we cannot move beyond because of limitations in the evolution of the regulatory process. So rather than, one of the advocacy points that we're making is rather than naming specific versions, specific standards, begin to move into naming base standard, like FHIR as a base standard, FHIR 4.0, well, not even the version, but FHIR, and then naming in regulation functional expectations of what systems should do. And then the industry would be developing the ways in which those functional expectations would be fulfilled. In some ways, that's what happened with the meaningful use requirement about doing consumer access via APIs, where, you know, back in 2016 when the final rule was published, FHIR wasn't even yet out of, you know, the minds of the people that created it, and yet the functional expectation that was written into the regulation coincided and looked at precisely the industry moving towards using APIs and FHIR. So I think through that mechanism, we would hope to see a more dynamic and a less restricted in terms of innovation and in terms of moving to newer versions and newer standards capabilities. So I think that's going to be.
Thanks, Walter. Yeah, I just observe, I think what you just pointed out is a really interesting case study of that mix and how people coalesce not only to FHIR, but to a couple of versions, and, you know, and so anyway, I think I'm really glad you pointed it out. Paul, as we wrap up on this question.
Yeah, absolutely. I mean, similar to Walter's experience, in the last 18 months, OCHIN has actually gone forward and implemented an entire team for government relations and policy review. In that process, I think now we have 17 people dedicated to that process, and actually created a program internally where the technical teams for interoperability meet with the regulatory and policy team on a frequency weekly. And because the amount of regulatory change coming out and policy change coming out, to keep up, we actually have to do a technical review of the documents, a policy review of the documents, work out what our response is going to be so we can actually articulate our comments in a more proficient and clear way. And it's a very tough thing. Small provider ambulatory organizations don't have those teams. Therefore, you don't see the comments coming back from them of the impact of some regulatory change. They tend to be mute because they don't have an organization sitting there helping them day in, day out that has the funding to actually do that work. So I think that one of the things we need to look at is the speed at which change is coming out is really impacting the smaller provider community. And definitely impacting things like public health departments who are often receiving a lot of change requirement right now with limited funding for those changes.
Yeah, no, thanks. So we're going to do the last question, then we're going to go up to Q&A. And so I'm going to ask you to go through, you've been succinct so far. I'm going to ask you to be even more succinct, to sort of in rapid fire, identify one or two recent interoperability advances that you find most interesting, most striking, most promising. It can be things that your agency is involved with, or organization, or just things that, being part of this world, you've observed. So we'll start with you, Walter.
Well, I think, and I can't not be unbiased on this, but I think that number one, the most transformative opportunity that we have is the whole evolution of standards into what we have today as open APIs and FHIR. I think that combination, just in the last year, let alone the last couple of years, have shown so much promise, so much opportunity. Sometimes, you know, a little bit of hype in some people's mind because in some ways it's been perceived as, you know, FHIR is replacing everything or FHIR is the solution for everything. That's not really the case, but in reality, when you look at the opportunity that FHIR has provided and that APIs and open APIs, I think it's completely transformative. We're moving away from what traditionally had been a document-based exchange, where we would be shifting documents back and forth and creating duplicative documentation of things, to a much more interactive, real-time, interoperable access at the point of source of the data that is completely transformative in our minds. So that we are putting a lot of emphasis into that.
All right, thanks. Alex.
I would agree with all of that and say just the sort of more recent, in the last year or two, or maybe a little more than that, but just the alignment of folks behind so much standards. So for fire, seeing the amount of support, and yes, there's some hype, but really seeing the alignment behind one sort of common standard has been really incredible and shows a lot of promise for getting alignment and in interoperability for the future, and also engaging folks like payers more in the interoperability space. A lot of what we've talked about when it comes to interoperability is like the clinical side and working with clinicians and hospitals and EHRs and thinking that EHRs are the solution to all interoperability. And now we're broadening that scope to be more inclusive of payers and other entities in the healthcare space and other IT, health IT, that's not just limited to the EHR and the clinician's office. And that's pretty incredible because there's a lot of data out there that can be shared that's not limited to just the what's in the doctor's notes, but is everything. And so seeing folks align on common standards to get all of that data together is pretty incredible.
Yeah, I think there's probably two projects that stand out to me right now. One is the request that went out, the Blue Button conference that was held around bulk fire transfer. So for providers and payers to be able to exchange information on a specific panel of patients. And so being able to get access to care gap data based off the claims information from a payer and bring that back and incorporate that as information to the provider at the point of service is a fantastic. So we're really excited about working on that one. The second one I would think about is immunization solutions. So immunization interfaces. I remember being at HIMSS many years ago, Farzad being in a room and going, it was almost like a no-wire hanger speech, is I don't want to hear HL7 version 2 ever again in this conversation. Right? We're going to use direct to do immunization systems. There's a great conversation taking place about a national gateway to immunization registries. And that work, I think, is really exciting, given that I'm working on 28 separate registries right now. And those are difficult to implement and have variances in their implementations as far as timelines. So having a single way for a provider community to say one vendor can build to one gateway and have access then to any of the registries in the country, given the authorization to use them, I think that's an exciting process.
Yeah, I think those public health opportunities are enormous. We did hear a lot of comments from public health as part of our TEFCA work. I'm really excited about those areas. I wish we had time, Walter, to get more into the social determinants of health work and the Gravity Project. Those are very exciting. And I'll re-mention the e-consent work that's actually going on. We do have a LEAP project, Leading Edge Acceleration Project, that's through the San Diego HIE to develop a fire consent IG. So being able to make these parts of the health IT ecosystem computable and movable are going to facilitate all of those use cases that really build up to what is the learning health system that we are all professionally invested in trying to achieve so that we can get to a much better place in healthcare for our country. It is a very exciting time indeed.
Great. Well, one thing I'll observe as I just move over, and Alex, I think you and John both alluded to it, is the joint work that ONC and CMS have done on burden reduction, and some of the work CMS has done on revising E&M coding. So in a sense, that the information that's exchanged is information that's viewed as of value to the end users and not solely to serve regulatory purposes. So that seems to me to be also pretty important in terms of interoperability advancement. So I think we've got about 10 minutes or so for audience questions. Please take advantage of having the panel here. And first, lead off.
Sure. So Michael Marchant with UC Davis. So one of the things that you talked about is identity. And there's a concept with some technology that's got a lot of hype around the concept of self-sovereign identity. And I have a digital identity. I might have my Twitter identity or whatever. Any thought from a regulatory or even just a conceptual standpoint of letting patients establish a healthcare identity that then they can carry into the organization, so that as opposed to today, each different organization establishes my identity, I can create my identity that I want to use for healthcare, and then kind of, I guess, your thought process around if that was to happen, how that might affect either from a regulatory standpoint or a technology standpoint of how that could work to helping that longitudinal record to come back together under the identity that I've established.
That's a tough one.
Yeah, I can start with, which is just, on the topic of, sort of patient matching, identity management. There's so much exciting things going on right now. And we did talk about USCDI, at least in the previous session, and how that's going to be enhanced by including, phone number and address so that you'll be able to better match. I think that's really exciting to think of the possibility of showing up at your doctor's office and, I have my digital certificate that proves who I am, and so, validate who I am. But we're probably a long ways from there, and I think we could all agree there, but there's a lot that is going on to bring us towards having people's ability to capture and use their information through their smartphone because of open APIs, et cetera, that is really going to enable different technologies like what you're talking about.
Yeah, and if I can add, so one of the things that's challenging about this whole concept is that we, as the federal government, are not actually able to look at unique patient identifiers. So when you're talking about an identity, like one identity that you bring with you from provider to provider or payer to payer, is, I think, a great concept. And then the identity and the ability to bring your identity with you, I think it is fantastic. But it's not actually, that specific space is not somewhere that we play so much, and we focus more on the patient matching. So how to take those various identities that you have at all the different places and wed them together. And so as John mentioned, that's a space that we've looked at. We both had RFIs in our interoperability rules about ways to promote patient matching and how to work with industry to ensure that we make progress on patient matching. One of the policies that we had in the CMS interoperability rule is would require payers to exchange your data as you move from one payer to the next. So if you're going to change payers, why would you completely initiate a new identity with the new one? You're still the same person. Would you be able to bring all of your data with you? And so those are just some of the ways that we're looking at getting at that longitudinal health record and getting to that patient matching without necessarily creating one identity, but ways to wed the different identities together. It's a very challenging space, and patient matching and patient identity is a huge challenge to interoperability.
I mean, I look at it from a technical standpoint. On the technical side, I remember about 5 years ago, there was an organization bringing forward an EMV chip-based digital identity certificate on a credit card. So you could actually say, this is me. And it was implemented by individual organizations. The issue I see there is, how do you get to something that supports a national scale with a market-driven approach? Right? Because we'll get to the point where somebody says they have an overwhelming market share, and are they now causing us to basically rethink how they should operate as a business? And so I would love to see some conversation occurring at a national level about digital identity and how we can get there. And with the changes to, I think it was the Ron Paul or the Rand Paul sentence in the one bill being removed, fantastic. At least we can have a conversation about what that means. And I'd like to see it move forward.
Other questions? Yeah.
So Keith Parker from Health Current. Question, you've talked a lot or a little bit about immunizations registries. A lot of immunization registries still rely on HL7V2 for the VXU OBX segments. How are you moving forward with the gap between the OBX segment and XML or CDA R2 and not having the payment sections in the CDR standards?
So from a technical standpoint, it is all focused currently on V2. So it's not moving towards an XML document type at all. We're seeing everything staying on that standard at the moment in the discussion. So I haven't got an answer for you from how we could get to some other way.
Not what I was hoping for.
I know.
Just because it's extremely difficult when most systems are moving toward an XML standard.
Yeah.
Yet CDC standards are V2, and most registries won't accept it without the payment information because they need that for their sustainability, for their revenue streams as well. So there seems to be a pretty big policy gap and standards gap on how we're going to support those on that. So I guess the no answer is frustrating, actually, as we're looking at it, because we're also talking a lot about transitioning to CDR standards, and it still doesn't support our public health. It still doesn't support EMS and some of the other items that are out there to move forward. The other question I have is on two parts, social determinants or some of the safety nets, since you're working a lot on that. Are you looking at general designation at all? As SAMHSA, it appears, or loosened up some of their restrictions on consenting. To move forward with that, are you looking at, or is anybody looking at some of the things around OTP? Because we talk a lot about Part 2, but I believe it's also, Part 8 with the OTP and the registry requirements that are out there, and how we can support those as well.
Yeah, I'm going to leave the policy conversation to my policy bigwig. I will say one thing. One of the things I do think is they didn't go far enough in the proposed change, and we put that into our public comment, where it still requires the naming of the specific provider organization I'm going to exchange with, and in a heavily document-based, query-based interoperability market today, it's very difficult to name the individual organization I will be sending the data to. So we require all patients to sign a consent if they're receiving those services. It's captured in the system to allow that data to flow out to a treating provider when a provider is requesting that information. And we are looking at that information and going, how do I make this work in a regional HIE market? So if I sign a document as a patient that says I'm allowed to send it under the rule through a regional information exchange to another treating provider who is a participant of a regional exchange, how can I do that when it's a query-based model in many of those exchanges, right? So that means the regional exchange now has to implement a policy of capturing consent at the regional exchange level, which doesn't necessarily have the one-on-one interaction or even the knowledge of the patient that exchange is being used to transition their data. So I think the question I would go with SAMHSA is, can they change one sentence in their proposed rule and move it from name the individual provider organization to allow for exchange as long as the patient has consented, and allow it to pass through a regional in exchange or any other form of exchange. If they could get past that one sentence, I think we would see an explosion of exchange occurring for substance use disorder.
Or potentially align with HIPAA standards and just get away.
Or at least align with the HIPAA standards would be even, yes, please.
I think we have time for one more question. Did you, John? And this will wrap up the panel, so you get the last question.
That was part of my question, but to build off of what you're saying, and I think part of the proposed rule also, and the current rule, is that they have to specify, if the patient has if they're participating in a substance abuse program, you have to kind of specify what that program is also. And I think earlier we talked about, marking it as sensitive, right? How do you see that playing out? Say, okay, I'll allow my information for these programs to be sent out, but not the substance abuse ones.
I think it actually goes further than that. So when querying for a patient, I'm sending the demographic information to find the patient.
Right.
If I respond and I've held myself out in the community to be a 42 CFR Part 2 organization, or it can be inferred that I am a 42 CFR Part 2 organization, and I've exchanged or acknowledged that patient's got treatment of any way, or even in my organization, I've actually violated the rule.
Right, and that's one of the difficulties we're having now, because we're trying to look ahead at the proposed rule and try to think about a way to develop an opt-in consent model for behavioral health, but we're struggling with that. So absolutely. I agree with your comments that you proposed to based on the proposed rule.
Okay, well, thank you, and I think at this point we're going to have to wrap up. Please join me in thanking our panel.